The world's first test tube baby, Louis Brown, was born. And in the last 40 years, ART clinics have strived to improve their clinical pregnancies and live birth rates. Newer drugs for ovulation induction and better culture mediums ensure that we have a blastocyst to transfer. The process of ICSI has truly revolutionized male factor infertility, and PGTA has ensured that we have euploid embryos to transfer. But despite all these newer inventions and techniques, the implantation rates have not dramatically gone up. The real eye-opener is the implantation failure, because we know that this is the rate limiting step for all ART clinics worldwide. Now, this is associated with problems with the embryo, problems with the receptivity of the endometrium, associated with interactions between the embryo and the endometrium, and in certain cases, iatrogenic causes because of the culture conditions in the laboratories. We also know that maintenance of early pregnancy, one of the most important hormones that drives this is the progesterone. In fact, it is the only hormone that rises through 3 successive trimesters, and a drop or insufficiency of the hormone leads to initiation of labor, miscarriages, recurrent pregnancy loss, or even preterm labor. There is a very old Zen saying which says, we teach best of things, we want to learn more, and me and my team are working for the last 15 years on progesterone and implantation. So my topic today is progesterone a spoil sport, or is it a game changer in ART practice? We all know that the premature progesterone elevation in controlled ovarian stimulation will give us lower implantation rates. To cut a long story short, we know that progesterone levels over 1.5 nanograms per ml were associated with a lower ongoing pregnancy rates following IVF or ICSI, and irrespective of the GnRH analog used for pituitary downregulation. That is, whether it was a long downregulation or an ANTAC cycle, if the progesterone was more than 1.5 on the day of HCG trigger, it was associated with a reduced ongoing pregnancy rates. Now, this picture clearly shows us the steep drop that occurs when progesterone levels go more than 1.5, and this is found in both the agonist and the antagonist cycles. The reason behind this is that it induces significant alterations in the gene expression profile of the endometrium, and approximately 140 genes are known to be significantly dysregulated. These genes are related to cell adhesion, developmental processes, and the immune system. So is there a solution? One of the options would be to continue embryo transfer in the fresh cycle as a blastocyst, hoping that in the next few days, the progesterone levels would stabilize. The other option would be to cryopreserve the embryos and transfer them in a subsequent frozen thawed embryo cycle. Alternatively, we also know that administering HCG at an earlier point in the follicular phase prior to the progesterone elevation might be the most beneficial, especially in patients who have previously exhibited elevated progesterone levels. When you look at embryos that are transferred, this paper very clearly shows us that even if you transfer the embryos at blastocyst level, there is going to be a reduction in the implantation, thereby giving you a lower ongoing pregnancy rates. So this paper shows us that when the embryos are transferred, be it top blastocysts or even top cleavage embryos, when the progesterone levels are lower, less than 0.5 to 9, and as the progesterone level starts going up, you will find that even the top blastocyst transfer rates come down and the clinical pregnancy rates come down from 40% per transfer to as low as 26%, even in all blastocysts. So we know that even if you try to transfer them in a blastocyst on day 5, you are going to experience some amount of implantation failures. Now, the other problem is that does one size fit all? So this demarcation of progesterone of more than 1.5 was not considered to be appropriate for all women or for all responses. And this paper shows us that progesterone elevation on the day of HCG trigger had more detrimental effects in low or normal responders, but did not affect as much in higher responders, particularly in PCOS. So according to Bosch, the threshold was 1.5 nanograms per ml, whereas this paper Wu quoted range between 1.5 to 2.75, depending on the follicular response. In fact, in a retrospective study of over 10,000 cases, they found that in over-responders, you could go to a cutoff as high as 2.75, 1.75 in normal responders, but they maintained the cutoff of 1.5 in poor responders. The other problem is the combination of slow-growing embryos and premature progesterone elevation. They found that if the blastocyst transfer was done on day 6 in patients with elevated progesterone, it compounded the asynchrony and gave further lower implantation rates. And this graph clearly shows us that as the progesterone levels went more than 1.5 going towards 2, if it was a day 6 blastocyst transfer, the live birth rates were dramatically coming down from 30% to as low as 10%. So the previous option of freezing all the embryos and doing a frozen thawed embryo cycle subsequently, does it ameliorate the effects of this elevated progesterone? And this paper published in 2015 doesn't seem to tell us that that is a good option, because in these patients we find that the top quality embryos are dramatically reduced when the progesterone levels are coming more than 1.5. And hence we know that even though you want to freeze all the embryos and transfer them next time, there is going to be some amount of effect on the embryo quality and subsequent implantation rates. There has been some talk of whether progesterone level should be measured through the stimulation cycle. And this paper tells us the benefit of measuring serum progesterone 48 hours before and seeing if it has been already raised before you give the trigger. So in such cases, we find that the effect of raised progesterone has been there for some time, and this will give us certainly lower implantation rates. This is an excellent paper which measures the change in progesterone measured on 2 occasions, 48 hours before the HCG and on the day of HCG trigger. And this algorithm tells us that if the ratio of the progesterone measured 48 hours before and on the day of HCG trigger is altered, then possibility of transferring these embryos in that thread cycle is low. So to make it more simple, if the progesterone level on the day of HCG trigger is more than 1.5 And the progesterone measured in the same patient 48 hours before is also showing more than zero point 0.9 or more than 1. The incidence of live birth rate is dramatically reduced to only 17%. Having said that, if the progesterone, which is measured 48 hours before, is less than 1, you have a good chance of implantation, even if you are transferring the embryos in the fresh cycle. There were some papers to suggest that to reduce the incidence of progesterone rise, we should be adding LH in the cycle. In a vast majority, there was no significant difference. However, there has been some papers to show that if the LH is added in the beginning of the follicular stimulation, rather in the late follicular phase, the incidence of progesterone rise is significantly reduced. And this paper then tells us that in these patients, particularly in poor responders or in patients with previous progesterone rise, it would be worthwhile not only giving FSH, but giving LH right from the beginning of the follicular phase of the stimulation so that the incidence of progesterone rise is dramatically removed. So progesterone can play a spoil sport in these patients. How can progesterone be a game changer? Now, when you look at luteal phase defects in ART cycles, we all know that luteal phase support is of paramount importance in ART, and this is because of the supraphysiological levels of estradiol, which are luteolytic. We also know that the pituitary LH, which is suppressed either by the GnRH agonist or by the antagon cycle, makes the corpus luteum or unable to produce adequate progesterone. We also know that the physical process of oocyte aspiration will deplete the granulosa cells, and hence progesterone supplementation is of paramount importance in luteal phase in ART cycles. Now we have a vast basket of progesterone options. The intramuscular progesterone gives you very good bioavailability, but patient compliance is poor because of the skin irritation, the local inflammations, and sometimes abscess formations. And the patient compliance to take injections if they are pregnant for 10 weeks of gestation is extremely low. We have been using vaginal preparations of progesterones. They are well tolerated. They have got very good local bioavailability. However, difficulty of administration, problems of vaginal itching, local irritation and discharge can reduce patient compliance. So the use of oral dydrogesterone was something which was thought of in the last 10 years, giving us a good bioavailability, and because of its unique retroprogesterogenic effect, also maintaining its bioavailability when given orally. We also know that there are certain studies to suggest that dydrogesterone in particular has an immunomodulatory effect, whereby the increase in PIBF, progesterone-induced blocking factor, will convert the immune system from Th1 to Th2, thereby giving us an embryo protective effect. There have been papers from 2005 by Ganesh et al. Where they have compared the use of oral dydrogesterone 20 milligrams with progesterone gel 8% or micronized progesterone 600 milligrams as luteal support in over 1,300 patients undergoing IVF treatment. And they have shown that there is not much difference in the pregnancy rates or the miscarriage rates in all these three groups, thereby suggesting that oral dydrogesterone could be an option that can be offered to the patients. Our group has been studying dydrogesterone as luteal phase support from the similar times, and we conducted our study in 2 phases. In phase 1, all patients received 600 milligrams of micronized progesterone vaginally, and then the patients were randomized to receive oral dydrogesterone 20 milligrams or placebo. The patients were divided into 3 groups: the normo responders, the hyper responders, and the recipients on the donor oocyte program. In phase 1, we found that both the groups gave us similar pregnancy rates without any statistical significance. However, in phase 2, we divided the patients to receive either micronized progesterone 600 milligrams vaginally, and we increased the dydrogesterone to now 30 milligrams per day. And we saw that there was not only a significant increase in the pregnancy rates, but which tended towards statistical significance. And we proposed that dydrogesterone could be superior progesterone as luteal support in ART cycles, in normo-responders, in hyper-responders, and in patients with recipients on the donor oocyte program. Based on our studies and Cochrane data, the 2 largest studies in IVF, the Lotus 1 and the Lotus 2 studies, also compared use of dydrogesterone 30 milligrams versus micronized progesterone 600 in Lotus 1 and micronized progesterone gel 8% in Lotus 2 studies. And both these studies, published in Human Reproduction of 2017, showed that the difference in pregnancy rates was tending to show a better pregnancy rate in the dydrogesterone group of 4.7 and a live birth rate of 4.9. And the Lotus 2 studies, which compared dydrogesterone with progesterone gel, again showed a difference in pregnancy rates favoring dydrogesterone with an ongoing pregnancy rate of 3.7 and a live birth rate difference of 1.9. So now we had an oral drug which was giving us a better pregnancy rates. But the Lotus studies were conducted in fresh embryo transfers, and there we know now that most IVF units are offering frozen embryo cycles, sometimes routinely, or their threshold to freeze embryos is very low. So we wanted to see the best progesterone which can be used in frozen embryo cycles and whether there is any window of progesterone which is the optimal window. And this paper shows us that progesterone levels more than 9.2 nanograms per ml on the day of embryo transfer had a significantly better ongoing pregnancy rates than patients who had low progesterone on the day of embryo transfers. There were papers to suggest that progesterone cannot be extremely high, and progesterone levels greater than 20 nanograms per ml also were associated with a lower pregnancy rates and, more importantly, a higher pregnancy loss. So this chart shows you the ideal progesterone level on the day of embryo transfer should be between 9 and 20, giving us the best ongoing pregnancy rates or live birth rates, at the same time giving us minimal miscarriage rates. Now, dydrogesterone, if it is offered as an option in frozen embryo cycles, doesn't get reflected in the progesterone, in the serum progesterone levels in the blood. And hence now there are papers to show that dydrogesterone also gives us comparable outcomes as compared to micronized vaginal progesterone in frozen embryo cycles. This is a retrospective study which was published in October of 2020. And this is again a study which shows that dydrogesterone gives comparable results when compared to the micronized gel for luteal support in frozen embryo cycles. But I think this paper of human reproduction published in 2021, the Midron uh, uh, study, which compared the use of micronized and dydrogesterone compared to only micronized progesterone in frozen thawed embryo cycle, showed that the addition of dydrogesterone 10 milligram twice a day to the routine protocol of micronized definitely showed better implantation rates. So ladies and gentlemen, progesterone early rise can be a spoiled sport, but needs to be in sufficient level in the luteal phase to give us good implantation rates. As Samuel Butler has said, life is the art of drawing sufficient conclusions from insufficient premises. I thank